Hey everybody, it's Dr. Wood, and today I want to get started talking about our OB-GYN section. And initially I want to talk about pregnancy and lactation. So we'll talk about pregnancy categories for medications and also getting into how we treat several different pregnancy-related complications. So in terms of fetal development, in terms of how medications can affect them, we're going to see that that the first trimester is really the most critical period for medications to influence a fetus, mainly because this is when things like implantation's occurring, this is when organogenesis is happening here. And the problem, though, is that a lot of women don't know they're pregnant initially, and they can go the whole first trimester without knowing this, meaning they could have unintended drug exposure to a fetus. And so you're going to see that how a drug affects this developing fetus can be kind of dependent on different factors. So for instance, the stage of pregnancy during exposure is important. Like NSAIDs can be used relatively safely during the first and second trimester, but should be avoided in the third trimester. Or the route of administration. So if you can use things that are not systemically administered, for instance. Obviously dose, duration, and all these things can also be playing a role as well. And the deleterious effects you can see in the fetus could be total destruction of the fetus. It can lead to structural anomalies, CNS abnormalities, all kinds of issues here, depending on the drug exposure and then when it occurred and how much occurred. So the FDA kind of breaks down, and this is kind of older nomenclature, but you'll see this being used still fairly commonly in kind of talk amongst clinicians, that will break down the FDA drugs, and the FDA will break down drugs into different categories. So it goes A, B, C, D, and X. Obviously, they did not learn their ABCs very well in elementary school, but we will not hold that against them. A is basically going to be any medication that either has well-controlled studies in pregnant females, or we don't really have any evidence to show there's any harm done to the fetus, meaning really remote fetal harm. This is really, really safe to give to pregnant patients, right? So these are things like vitamins like folic acid. These are things that are pretty natural, like fat-soluble vitamins like A, D, E, and K, So not many things get considered category A, mainly because it's really hard to do controlled studies in pregnant females. That is a protected group, and it is not ethical to do so. B is either going to be one of two categories. One could be that because we can't do fetal studies in pregnant human females, we can do it in animals, right? So sometimes that may not be a complete one-to-one extrapolation from, say, mice or monkeys to people, but you may find some crossover there due to our mammalian origins. Looking at this, though, something can be categorized as a category B, assuming that it has either animal studies that don't indicate any risk to the fetus, and we don't really have any controlled studies on human women, and obviously we don't have any reports of damage being done to a fetus, or if we have animal studies that do indicate some degree of risk, but we have human studies that actually don't demonstrate any. So we've had some risk seen in animals, but in humans we've had good enough studies to say, no, this is really unlikely to be a problem. Most of these things are really safe to give to pregnant patients. I would feel comfortable giving this to my wife if she was pregnant, right? So pretty safe. The problem you get into is when you get into these later categories here. D and X are pretty straightforward. Category D means we know that there's absolutely risk to the fetus, but there may be some situations in which the drug may be beneficial to the mom, and those benefits may outweigh the risk to the fetus. This is extremely rare that this occurs, and you really don't want to be using these, if at all possible, in these pregnant patients. So for instance, if it's something where it's like life or death with the mom, where if the mom dies, the fetus is obviously going to die, but there's known risk to the fetus. This may those risks may be outweighed by the benefits, right? So pretty rare though. Category X is going to be something that is absolutely contraindicated. There is no reason to give it to a pregnant patient because there are no way that the benefits could outweigh the risk. So for instance, something like Accutane, used for acne, it's okay if you have acne while you're pregnant, right? That's not really going to be as big of a deal as compared to the damage it may do to a fetus, meaning complete destruction of that fetus. So in those cases there, it's completely contraindicated. Category C is where it gets a little bit more tricky because most things are going to fit into category C. Basically, this is things where you say, well, we don't really have enough evidence to show. Animal studies may indicate risk, but we don't really have any adequate controlled human studies to show one way or the other. And this is purely a risk versus benefit sort of scenario. And again, most drugs fit into this category. So it's not super useful to say that something is a C category, because most things are going to be in the C category unless they're very obviously an A or a B or a D or an X. And so because of that, the FDA has tried to get to more useful nomenclature to try to look at things specifically related to lactation, to pregnancy, and then also patients who may be of some reproductive potential, right? And so kind of what effects drugs may have on that in particular. So here's some examples of what information looks like, and this is taken from LexiComp, which can be gotten to through UpToDate. And so just to give you an example of what it looks like, and again, categories are nice. It's nice to be able to say you're a category D drug, so there may be some indications to use it, but mostly don't, right? So it's nice to put things into little confined boxes. But unfortunately, that may not be super useful, especially for things that may be a category C. And so a lot of times they'll give you more information. And so while reading is difficult, you want to make sure you do read this stuff to make an informed decision whether this drug is going to be worth it to give to your pregnant patients, right? So kind of looking to see what the evidence has shown in terms of risk, are there guidelines available, and things like that. So for instance, here's warfarin, which we know to be a vitamin K antagonist. It's a very effective blood thinner. You can see here it's a category D for women who have mechanical heart valves because they're quite at risk for developing clots, but for everyone else it's a category X. Okay, so just don't use it in pregnancy. They can also give you information on breastfeeding to see will the drug cross over and have any effects on that particular fetus or particular newborn after it has been born and is being breastfed. Here's an example of a category B with ondansetron, which we'll talk about more in its use in terms of pregnancy-related nausea and vomiting coming up in just a little bit. Again, these are things that you want to do the reading to make sure that it is, you determine that it is safe and reasonable to give to your pregnant patient, or if you have guidelines to back you up. Because if a bad effect did occur and something happened, you were legally on the hook, you want to be able to go back and say, yeah, this is why I decided to use this drug based off these things. Here's the evidence that I used, and that looks a lot better than like, well, I don't know, I just used it. So you want to have at least some educated reason for doing what you do. So obviously in pregnancy, you'd like to avoid all medication use if at all possible, but you may need to consider things like, what kind of acute or chronic conditions that patients have before they became pregnant. Those things just don't go away all of a sudden. And so you want to identify any medications used prior to conception and determine whether this is something that you can either eliminate, you can try to get them to switch over to something else, or you may be able to initiate maybe some non-pharmacologic therapy to maybe make it not essential. Ideally, this is done prior to the baby, prior to the woman getting pregnant. Is that always going to occur? No, it does not. And so because of that, you want to at least make sure you have good conversations with your patients, make sure you're discouraging self-medication, make sure you tell them what drugs are safe or not safe to use, depending on what sort of conditions they develop here. And if we have to use medications, try to mitigate the risk as best we can, either with the dose that we're giving, the route that we're going with, or the dosage form we're going to use. So here's some common pregnancy-induced conditions we're going to talk about more specifically, and which medications may be useful to help treating these that will help to mitigate risk done to the fetus. In terms of nausea and vomiting, this is a super common thing you're going to see here. You tend to find that pregnant women, their sense of smell tends to be heightened and may be really triggered by certain smells. In some cases, it may be their husband, as it turns out. But this is a common thing you're going to find. So in terms of what we can do, dietary changes are always effective. So if certain smells get to them, obviously cut out those foods out of their lives, right? In terms of drug therapy that we can use, a common combination that is recommended is a combination of vitamin B6 or pyridoxine plus doxylamine, which is an over-the-counter sleep remedy. It's Unisom, right? It's an antihistamine drug, and we know based on our toxins in GI that antihistamines have antimuscarinic properties that have antiemetic properties, right? So both of these are category A, right? They've been used forever. We know there's no harm done to the fetus. And in fact, they have a long-acting preparation they have combined together called diclegis. However, it is pretty expensive. So if you want to recommend them just getting over-the-counter B6 and doxylamine, that'll work just as well, right? Other things we can use additionally include things like metoclopramide and promethazine. We know these are going to have some risk for things like extrapyramidal side effects based off of their dopamine antagonism, but these are old school, been used forever, pretty safe to use for pregnant patients. Keep in mind that all these things are going to be somewhat sedating. So if you have someone who's pregnant but they are still working, which is a lot of pregnant women, you can use things that are non-sedating, like our 5-HT3 antagonist. So ideally you want to start with something that's a category A if at all possible, but if you need to, switch over to something like ondansetron, which is now categorized as the category B. We remember these are blocking serotonin. Again, these are all going to be equally efficacious here, but they tend to be more expensive than some of your other agents, like promethazine, for instance. Again, not expected to harm infants, especially either with breastfeeding or during pregnancy itself. In terms of heartburn, things we can do here include eating more frequent and smaller meals to try to help out with that load. Again, in later stages of pregnancy too, they're having a lot of mass pushing up on the diaphragm and into the stomach, which can help to worsen those heartburn symptoms here. You do want to be cautious if you're going to use an antacid, because even though they have relatively little effect on a fetus, because most of them are just electrolytes, you do want to avoid salt-containing products like sodium bicarb, mainly because you can find that can have an increased sodium load. It can worsen blood pressure, and we'll talk about pregnancy-related hypertension in just a little bit. Things like Carafate can be really useful. H2 antagonists have been used for forever and have no known problems here. Obviously, cimetidine I still would recommend avoiding due to its CYP antagonism. And then proton pump inhibitors like pantoprazole or omeprazole are probably safe, but because they're newer, they have less evidence for use. I'd probably use it as a backup if the H2 blockers are not going to be reasonable or effective. In terms of constipation, obviously, pretty much the same thing goes for these patients as anyone else. Increasing your fiber, getting better water intake, and consider some moderate exercise. We do like bulk forming laxatives, mainly because, and these are going to be a drug of choice, because they are not absorbed. So again, if we can use anything that has no systemic exposure, that has the least amount of risk for a fetus, so methylcellulose, your psyllium husk, and things like that can be used here. Stool softeners, even though docu states category C, probably has pretty limited drug exposure to the fetus. And then we're seeing more and more use of osmotic laxatives, especially things like polyethylene glycol or Miralax, since it went over the counter, so it could be used additionally. Things like stimulant laxatives like Senna or bisacodyl should be used occasionally. We know there's some risk with using those chronically. They can be habit forming, can lead to some rebound constipation potentially when they're not being used there. And mineral oil is typically not recommended due to some risk for decreasing fat soluble vitamin absorption, which are going to be your vitamins A, D, E, and K. In terms of hemorrhoids, the best way to avoid these is to avoid constipation, but we have a lot of external preparations we can use to help out with this. Things like preparation H, which is going to be a combination of hydrocortisone and or phenylephrine that can help with decreasing inflammation and constricting down that blood vessel. Obviously, preparations A through G were total failures, which is how we led up to preparation H. Things like witch hazel can also be useful because it's an astringent and will help to constrict some of that tissue around that blood vessel there, so that can be used as well. And then sitz baths may be also beneficial. In terms of diarrhea, stool bulking laxatives like or agents like psyllium husk or methylcellulose can also be recommended here. And then loperamide has been used in the past and helps to kind of slow down the GI tract by working on those GI opioid receptors. That could be a pretty reasonable option, assuming bulk forming agents are not working or maybe not appropriate for your patient. So getting into pregnancy-induced hypertension, you're going to see that patients may have a pre-existing hypertension coming in, which may be a chronic issue, or they may develop gestational hypertension during the pregnancy itself. Not only this, but you can also see things like a lot of proteinuria associated with this blood pressure increase, which leads to preeclampsia and can complicate, a fair number of pregnancies. And then more severely, you can see as the pressure increases, as they're getting more proteinuria, this can lead all the way up to eclampsia, which are basically these tonic-clonic seizures in someone who has this pregnancy-induced hypertension. So obviously this is a medical emergency you want to treat immediately. But the treatment for this particular seizure is going to be a lot different than what we've seen in the past. In terms of management here, things we can do include things like activity restriction, stress reduction, which usually includes telling the partner to be quiet for the most part, and some mild exercise can help out with this. The issue with activity restriction is that due to increased levels of things like estrogen, this can predispose these patients to venous thromboembolism. We'll talk about why that is a little bit later on when we get more specifically into talking about estrogen and progestin. Calcium may be beneficial here, although that can worsen their constipation if that's an issue, so one thing to consider. And then the drug of choice if they are developing true blue eclamptic seizures is going to be magnesium sulfate. And so you'll probably see the biggest doses of magnesium ever given on the L&D ward. Typically they're giving anywhere between 4 and 6 grams very quickly, over 15 to 20 minutes, and then they'll be put on a continuous infusion. Again, most of the time, like for like a cardiac code, like if you have someone who's in torsades, like 2 grams of magnesium is what they use. They're using huge doses here for these pregnant patients. Keep in mind that benzodiazepines and phenytoin are not going to be recommended because these are teratogenic. These will cause issues in that developing fetus, so these should be avoided. For chronic management, so again, you can't put a patient on a continuous magnesium drip through the whole pregnancy. We have other agents here. So we used to use methyl-dopa as the drug of choice, which basically work kind of similar to things like clonidine and guanfacine to help reduce sympathetic outflow, to help reduce blood pressure. Nowadays, you may see more use of things like labetalol, which we know to be a 3rd-generation beta blocker, which is good either orally for chronic management or IV if you need sort of acute drops in blood pressure. And then also you can see things like calcium channel blockers like your DHPs, like amlodipine can also be used here. We'll see the calcium channel blockers can also be very beneficial if patients are having premature contractions. So you can kind of pull a little bit of double duty there, as we'll see in just a moment. And then things like rapid IV treatment can be achieved with things like nitroglycerin and then nitroprusside potentially. In terms of gestational diabetes, we're going to see that in many pregnancies that you're going to have a degree of glucose intolerance that occurs here, and we have to check for this for most patients. Most of them will be screened between, say, 24 and 28 weeks of gestation here, and typically this does resolve, assuming the patient didn't have any issues with glucose homeostasis prior to the pregnancy, but it may put them at bigger risk for developing type 2 diabetes down the road. And so ideally what we'd like to do is to modify the diet as best we can to try to get them to keep that under control. But if we have to treat that, the things like insulin is probably going to be the drug of choice. This is not great because of the fact that patients now have to start injecting themselves, but it's relatively safe for the fetus. And again, it looks a lot like the insulin that we produce, so it's not really teratogenic. It also doesn't cross the placenta because it's a fairly large protein. Things like glyburide have been used in the past, things like metformin, but these appear to be safe, but it just depends on the provider. And usually if they do have this, they'll be referred to a specialist and they can make more individual decisions on what is going to be most appropriate. But for the most part, you'll see a lot of insulin being used if dietary modifications are not sufficient. So, as I mentioned, the thromboembolism is a risk for these patients, mainly because this increase in estrogen levels is going to cause the liver to produce more clotting factors. So, basically, you're going to see this increase in risk, especially if they're bedridden because they're on activity restriction due to blood pressure issues or something. This is the risk. And so, we can put them on things like enoxaparin, which is a low molecular weight heparin, or unfractionated heparin potentially for treatment of this. Typically, if patients do have an issue with VTE or if they're high enough risk, we'll go ahead and put them on this, and they'll be on it for a minimum of 3 months and at least 6 weeks after the delivery itself. By then, estrogen levels should have kind of gone back down to a point where this risk for VTE is going to be lessened. And then other things to consider, things like UTIs. So even if it's asymptomatic, you always want to treat this. Nitrofurantoin is a pretty good one here that unfortunately doesn't cover Proteus species, so it may not be effective. It could be a good initial therapy, but then you follow up with a culture to see how it's working, see if it's going to be sensitive to the bacteria is sensitive to it. Basically, this is going to help to block cell wall formation. That's how it's going to be working there. That's not going to be effective. Then something like amoxicillin can be used as a backup, and then cephalosporins are all going to be relatively safe. Keep in mind, though, depending on if they have like recurrent UTIs or if they have resistant bugs, these may not be effective. In terms of pain, acetaminophen is going to be the drug of choice for most patients. If they cannot get away with this and you have to use an NSAID, use them during the first or second trimester. These are relatively safe. It's that third trimester, though, where NSAIDs are not going to be recommended, mainly because they can close down the fetus's ductus arteriosus prematurely and lead to impairment of normal fetal blood flow. The reason for this is that prostaglandins will keep that ductus arteriosus open. By giving an NSAID to get rid of those prostaglandins. Occasionally, patients may have enough pain where they need to be put on opioids potentially, and so something like morphine tend to be relatively safe if used for short periods of time. But certainly, we've seen that patients can become, dependent on opioids. They're on it throughout the entire pregnancy, and that can lead to things like neonatal abstinence syndrome once the baby is born. So, there's plenty of patients I've seen in the NICU whose mothers were using opioids throughout the entire pregnancy, and they come out, and those babies are used to those opioids, and now they're withdrawing from it, just like any adult patient would if they were cut off from their source of medication. So other things to consider too is mental health during pregnancy. I think a lot of times this is something that is gone unnoticed or unaddressed. And I think nowadays, though, that the stigma is starting to kind of lift off of this a little bit, and more patients are being treated effectively here. Because again, a lot of patients may have had anxiety or depression issues prior to the pregnancy. Doesn't mean they're going to go away, or they may be induced during the pregnancy itself, right? And so not only that, but mommy guilt is a real thing, and so a lot of people are concerned with taking any medication during pregnancy, even though they may really have a true need for it. And so when you think about things like depression, especially postpartum depression, this is a big deal that can occur, even within the first month after childbirth. And we're starting to recognize it more and making sure that we are being adequately following it up and make sure we're treating it with if it's needed. And so again, the more people that recognize it, the more people that don't have a negative stigma against it, the more likely we are to help save potentially a few lives here. For the most part, SSRIs are going to be the most safe and effective treatment here for these patients. We do know there is some small risk associated with use, especially throughout the pregnancy. So for instance, we know that adult patients can withdraw from SSRIs if they're cut off cold turkey. Same thing can happen for newborns once they're born, but that may be mitigated for things like if they're being breastfed. Maybe they'll get some transference over from the mom potentially. So examples, things like citalopram and escitalopram can be used here. With paroxetine, there is a risk for cardiac malformations, especially if used during the first trimester. So that may be something you want to avoid and maybe use one of these other agents instead. TCAs may be used as a second line agent, maybe as a backup. These are not going to be great in terms of breastfeeding potentially, because they can cause hold on secretions, mainly because of the anticholinergic effects. But in terms of teratogenicity, it doesn't seem like it's going to be a big issue. But things like amitriptyline, nortriptyline, or disipramine have been probably used most frequently. And then all patients who are likely to get pregnant or want to get pregnant or just in the off chance may become pregnant should be getting folic acid, right? And just because you're not pregnant doesn't mean you have to, or just because you're not trying to get pregnant doesn't mean you can't take prenatal vitamins that include enough folic acid here. Main reason for this is because we want to prevent neural tube defects. Typically, if you start taking folic acid as soon as you become pregnant, that's kind of too late to begin with already. And in fact, especially if patients have had a history of an infant with neural tube defect, they recommend even higher amounts of it. So typically, most females, 400 micrograms a day is sufficient to protect against neural tube defects. They've had that history, they actually recommend 4 milligrams, right? So kind of getting a tenfold increase there in terms of their dose that are recommended. Very few women actually follow this recommendation, so it's really important if they're thinking about getting pregnant or there's an off chance they could, a little extra folic acid never really hurt anyone, right? So other things to think about. So tocolytic therapy. This is going to be good for patients who maybe are having premature contractions. And so we can do things to try to slow down and decrease those uterine contractions for these patients here. So these are going to be smooth muscle relaxants for the most part. These include things like beta agonists, like terbutaline, which is a beta 2 selective agent, very similar in effects to albuterol, but may be either given PO or IV. Magnesium may be somewhat useful here, but I also see a lot of calcium channel blockers being used, especially things like nifedipine. This is also really handy if they also have blood pressure issues. Something like nifedipine can help out and kind of pull double duty in those cases there. NSAIDs have been used in the past, so things like indomethacin. Again, this should be used under careful watch by a specialist, and maybe something like indomethacin is preferred if risk for hypotension is high and they can't really tolerate something like a beta 2 agonist or a calcium channel blocker. Other things we can use potentially include progesterone. This will help to decrease uterine contractions here. And so this used to be a specialty compounded product that would be given as an IM injection. You see this a lot being used for women who have a history of preterm birth as well to try to prevent a second preterm birth. And so nowadays we have a compounded product that's more expensive, obviously, but it's hydroxyprogesterone. So this could be recommended for really high-risk women for having a premature baby. In terms of things to speed up labor, right? So if you're ready to have that baby, if you're ready to get the bun out of the oven, so to speak, we can have medications that can either help out with cervical ripening or to help actually stimulate contraction of the uterus. And so we have things like prostaglandin analogs. Now, we've talked about prostaglandins before as being abortifacients, meaning you don't want to use them if patients are pregnant, say, early on in the pregnancy, because it can actually cause expulsion of the fetus. But these can be used when you're ready to have that baby in order to help with the cervical ripening and help out with this. So dinoprostone or Cervidil is given actually vaginally. It's actually placed right against the cervix, and that will allow for that ripening to begin, allow it to get prepared for the actual labor process itself. And so you can either remove this once labor begins, or after about 12 hours or so. If it's not working by then it's probably not going to work at all. There is risk for things like fetal bradycardia and arrhythmia, so you do want to watch fetal heart rate, which you'd probably be doing anyway. And then something like misoprostol, which we saw used previously for peptic ulcer prevention with NSAIDs, can also be used. Now, the other thing you'll see probably more commonly is going to be oxytocin. This is something that works as a stimulation of uterine contractions. This is something that the patient's going to be releasing themselves anyway, but we can try to help this process along by giving bigger doses. And so this is something that you'll see that as a woman gets closer to having their baby, that they're going to have upregulation of oxytocin receptors on the uterus. That helps make the drug that much more effective. And so this is going to be something also you do want to be cautious with, because there are some side effects, and that can include things like PVCs can be seen in other arrhythmias, and then there is a small risk for bleeding anyway, which could be a risk because patients again are giving birth, and there's inherently a bloody process to begin with. So you do want to watch out for that when using oxytocin. In terms of pain management, you're typically going to see this is we're going to mitigate systemic exposure of the fetus to medications by giving epidural infusions. And so frequently you'll use a combination of an opioid like fentanyl and then a local anesthetic like bupivacaine. The benefit here is that depending on how much is being given and sort of the position of the patient in terms of where gravity is forcing the drug, is that if they're more upright, you're going to see that the drug is going to be kind of located down at the bottom part of the spinal column, and it's going to be affecting sort of the lower extremities. And as they kind of lean back and you see the drug trying to travel up, it can then extend the degree of numbness and pain relief that it causes up towards, say up to the chest, for instance. And so based off this, you can kind of dictate how well the drug is going to be working based on positioning of the woman, and then also how much you're giving there. Because again, you want to make sure you're not having too much numbness and too much analgesia here, because you want the woman to feel something so they can actually try to push and coordinate with the providers, make sure they actually get the baby out, which is why you do see prolongation, especially of the early stages of labor. But some other risks you can see there as well include things like hypotension. You can see itching associated with the opioid being used here, some decrease in ability to void, because patients may not feel that they have to go to the bathroom, but this is something they'll probably get a catheter anyway. And then you can see, due to the actual epidural injection, a spinal headache that can occur afterwards. So that's it for the labor and pregnancy section there. I'm going to go ahead and cut it off here, and then next week we'll follow up and look at our estrogens and progestins and talk about things like hormonal replacement therapy and oral contraception. So if you have any questions, let me know, and I'll talk to you soon. Thanks a lot. Bye.